Hello and welcome to Insight Ophthalmology. This is Dr. Amrit welcoming you to the Squint series again. Today we are studying how to measure deviation using the PRISM cover test. So first, let us try to understand the optics of the prism cover test. Before that, as I explained to you in my previous video in which we studied measuring of deviation using the Krimsky's, modified Krimsky's and the Hirschberg's corneal reflex test. So there we studied that how a prism, if you take, it bends the light always towards the base of the prism. However, the image is always shifted towards the apex of the prism. So that is one point that you must remember. Now let us go into the optics of the prism cover test. Now over here, let us imagine that it is as if you are looking at an object which is of yellow color here. So this is your right eye which is represented in OD, and then you have your left eye which is represented in OS. Okay, so here as we know fovea is slightly temporal, so the part of the retina which is nasal to fovea is represented in pink color, and the part of the retina which is temporal to the fovea is represented in the blue color. Now what if the left eye was actually having esodiviation or the esotropia or an inward deviation? What happens is that the image of the object in the right eye, which is looking straight forward, which does not have any sort of squint, is being formed at the fovea. However, if you look at the left eye has esotropia or inward deviation, and therefore you can see the image is actually formed on the nasal half of the retina, that is in the pink zone. So this is very important point. Now what will happen if we now cover our right eye? If we cover the right eye will not be able to take fixation. So now the onus of fixation lies on the shoulders of the left eye. So left eye now is supposed to take fixation. However, the left eye was inwardly deviated. So therefore, when you put a cover in front of the right eye, the left eye will now move outwards in order to take fixation. And by taking fixation, what I mean is that the image of the object will be now formed on the fovea. Initially it was formed somewhere here on the nasal part of the retina, but after you force the left eye to take fixation, it will form on the fovea. And because of the Hering's law, what will happen to the right eye? The right eye also will show corresponding inwards movement. Now, so basically what is happening, the sensory origin of this reflex movement is because of the stimulation of the peripheral retinal area in the deviated eye. In this case it is the left eye which was deviated. Okay, and once we force it to take fixation, this eye is going to turn in such a way. Okay, so it's not just about esotropia. Any eye with squint, okay, when you force it to take fixation, the eye is going to turn in such a way that the fixated object will now move towards the fovea, right? So I hope that is clear to you. Now, and this movement which the deviated eye makes is called a redressal movement. So in this case, the left eye actually moved outwards in order to take fixation. Outward means that it is moving towards the left side, or it is moving temporally in order to bring back that image onto the fovea. Now this movement is called the redressal movement. Okay, and this redressal movement is more of a quantitative movement. What I mean to say is that the amount of redressal movement that happens in the deviated or squinted eye is directly proportional to the amount of squint, and it is directly proportional to the distance of the fovea from the stimulated peripheral area. So suppose here this was the point where the image was being formed somewhere on the nasal retina. Okay, this was where the image was formed. However, this was where the fovea was. So if the distance between these 2 points is more, obviously the redressal movement will also be more. Okay, so in more simpler terms, the more is the squint, the more peripheral is the image formed, and more is the redressal movement that the eye has to make in order to bring that image onto the fovea. So I hope that redressal movement concept is clear to you now. Now, what if we use a prism in front of that esotropic left eye? Okay, and as I told you in the previous video, what type of prism are you going to use here? In esotropia, Where is the eye deviated? The eye is deviated inwards, and therefore you are going to place the apex of the prism also inwards and the base will be outside. So therefore the type of prism that you're using here is a base out prism. Now what did I tell you about prism? A prism will bend the ray of light towards the base, okay, so towards this side. So now you can see the initial image which was formed in the nasal retina is now formed closer to the fovea, okay, because of the bending of rays which is happening towards the base of the prism, right? So as we start putting the prism, initially we will put prisms of, say, lesser power. Say initially we put some 5 prism diopter base out prism. So because of the bending, say the image now shifts here, but still it is present on the nasal half of the retina. So now still you are going to see some amount of redressal movement towards outside. Now suppose we increase it to 10 prism diopter, again the redressal movement will decrease. That means the image is moving closer to fovea, but it is still not on the fovea. Okay, so now we are going to suppose we increase it to about 15 prism diopter. The image is shifted exactly on the fovea. Now, is there any need for the eye to show any redressal movement? No. If the image is formed on the fovea, there will be no redressal movement, and that is the spot, okay, where the prism strength will be equal to the amount of deviation. So I hope that you understood this concept of the prism cover test. Okay, so you're going to place the prisms of increasing power in front of the deviating eye and check for the movement of the redressal, and that movement of redressal is going to decrease as you keep on increasing the power, and at one particular point the movement is going to totally stop, and that is a point where the prism strength is equal to the amount of deviation. Now, what if you were to check whether the amount of deviation that we have measured is correct or not? So in that case, now what we'll do is we'll increase the amount of prism further. So suppose we got no movement at 15 prism diopter, we're going to increase it to 20 prism diopter base out prism. So suppose this prism is 20 prism diopter. Now what happens is at 15 prism diopter, the image was being formed at the fovea. But now at 20 prism diopter, the image will move further away from the fovea, and now it has entered onto the temporal aspect of the retina, right? So at this point, if we do our alternate cover test, the movement of redressal is going to get reversed. Okay, that means instead of moving outwards, now the eye is going to show an inward movement. So what does that mean? It means that after one point, okay, we have, by increasing the prism, the strength of the prism, we have actually induced exotropia in this patient, and now the eye is actually showing a reversal of movement. Okay, it is called reversal because it is in the opposite direction to the movement which was seen previously, right? And this is called the point of reversal. So while doing a cover test, if you see a point of reversal, that means change in the direction of the redressal movement, it gives you an idea that you have actually exceeded your exact point. So at this point, now you're going to again go back to your previous strength of the prism. So in this case, we go back to 15 prism diopter, and this is how you cross check your prism power. Okay. So let us now summarize this concept of prism cover test or the redressal movement. So redressal in the prism and the cover test is basically a psycho-optical reflex that occurs when the eye is forced to take fixation. And here we're talking about the deviated eye, right? So as the deviated eye takes fixation, the peripheral retina is going to get stimulated, and there will be a redressal movement in that deviated eye in order to bring back the image onto the fovea. Now this amount of redressal movement will be proportional to the amount of squint, obviously. And now you're going to keep on increasing the power of prism placed in the front of the deviating eye. Start with the low prism power and then keep on increasing. As you increase the power of the prism, the redressal movement is going to keep on decreasing, and as the image is going to come exactly onto the fovea, you will see that at one point there will be no redressal movement. Okay, and that is your prism power. Now if you were to go one step further and increase the prism power by one more step, what will happen? The redressal movement will now reverse. Okay, so you will see a point of reversal. At that point, you know that there's no use of increasing more, no use in increasing more prism power. So now you're going to come back and choose the prism where you did not see any movement. So that is your prism cover test. So in prism cover test, basically we are measuring the angle of deviation using the prisms, and simultaneously we are doing an alternate cover test. Okay, so that was the optical principle, right? Now the thing is, before you start doing the prism cover test, you are always supposed to do your cover, uncover and alternate cover test. The alternate cover test specifically you're supposed to do because that will help you establish the nature of the deviation. You should know first of all whether you're dealing with an esotropia, an exotropia, or you're dealing with a hyper or a hypertropia. Because if you do not know what kind of squint you are dealing with, how are you going to place the prism in front of the eye? Now, as I told you in the previous video also, when you're dealing with an esotropia, that is an inward deviation, you're supposed to place the prism in such a way that the apex is toward the deviation, right? So in esotropia, you put a base out prism. In exotropia, you're supposed to put a base in prism. In hypertropia, you will put a base down prism. In hypotropia, that is downward deviation, you will put up a base up prism. And in all these, you are going to put the prism in front of the eye where you're supposed to measure the deviation. So here you're putting in front of the deviated eye. Okay, now one more important concept is that when you have put up a prism, that eye is not going to take fixation. The other eye without the prism is the eye which is going to take fixation, and the eye which is present below the prism is the eye that you are measuring the deviation of. So I hope that is clear to you. So the fixing eye is the eye without the prism, and the movement of the eye behind the prism is neutralized. So you're checking the deviation of the eye in which there is prism. Okay, now always carry out your prism cover test at distance and also at near fixation. It is very important that you carry out at distance as well as near fixation. Moreover, you're supposed to carry out in all the 9 gazes of the 9 positions of the gaze. Now, if you're doing it at a distance, make sure that the distance fixation, you give them at least a 6:9 visual acuity symbol. Okay, and if the patient is preliterate patient or kids, then you can use maybe some electronically operated moving mechanical toys or some projected moving cartoons also. For near fixation, usually the distance is about 33 centimeters, and the fixation targets are these tongue depressors or these ice cream sticks onto which you can actually stick these accommodative targets. Now, for the purpose of prism cover test, either you can use these loose prisms or you can use the prisms which are mounted on a bar, right? So loose prisms are like this. You can actually pick up one prism at a time, put it in front of the patient based on how you're going to put it, based on the type of squint. Okay, that is base in, base out, base up or base down. And the prism bar cover test, in prism bar cover test, basically you're going to use these prism bars. Okay, so prism bars are nothing but the prisms are going to be mounted in such a way, like suppose we have this horizontal bar. In the horizontal bar, the prisms are mounted in such a way that the base is going to be present horizontally or laterally, right? Like this. So this is how you have the horizontal prism bars. Whereas in the vertical bars, the prisms are going to be oriented in such a way that the bases are going to be either up or down. Right, so that those are your vertical prism bars. So you can also hold it in such a way that if you want to use it as a base up prism, you're going to hold it in one way, and then if you want a base down prism, you're going to turn them down and then use it on the patient. So let us see how we carry out this prism cover test. Suppose this is the patient that we want to test. In figure A, you can see that the right eye is showing what? So if you're looking at the patient always, this is your right eye and this is your left eye. Okay, I hope that is clear to you. So in right eye, you can see that there is an esotropia. Obviously, there is this Hirschberg's corneal reflex test also. If you carry out, you can see that the reflex is temporal. That means we are dealing with esotropia. Now, if you put a cover in front of the left eye, what is happening to the right eye? The right eye is moving outwards to take fixation. That again confirms that you are dealing with a case of esodiviation. If you put a cover on the right eye again, what is happening on the alternate cover test? the left eye is now moving outwards. That means you're dealing with a alternating esotropia. Now what you do, you start doing your prism cover test. Because we're dealing with an esotropia, we're going to put a base out prism with the apex towards the deviation. And now you can see that as you put cover, as you keep on switching the cover between the right eye and the left eye, simultaneously you are also checking the movement of the right eye behind the prism. You can see the movement is outward. So at one point, as you can see in the figure F, the reflex is in the center, but obviously what we are looking here is the redressal moment. There's no redressal moment, so that is your point of neutralization in the prism cover test. Now, this very important point that the prism cover tests are supposed to be performed in all the positions of the gaze, right? So there are two ways in which you can do. Either the fixation target you can put straight up, it can remain fixed in the primary position, and you can actually manipulate the patient's head in such a way that the eyes move in all the 9 positions of the gaze. Or what you can do is you can take the fixation target from one position to the another, just like you check for the movements of the eye, okay? And then you carry out your deviation, you carry out your prism cover test in all the gazes. Of course, the first way is much more convenient. Now, the reason we are doing it is because if the angle of deviation is equal in all the 9 positions of gazes, it means that we are dealing with a comitant squint. Okay, so in comitant squint, basically, there is no paralysis of any muscle, there is no restriction of any muscle, and in simple words, it is just a sort of balance which is disturbed between the two eyes. However, if there is any disparity in the angle of deviation in different positions of the gazes, it means that we are dealing with an incomitant squint. Okay, so if the angle of deviation is equal in all the position of gazes, we are dealing with a comitant squint. If the angle of deviation has a disparity in different position of gazes, it means that we are dealing with an incomitant squint. So I hope that is clear. Now, an incomitant squint can be restrictive squint, it could be paralytic squint. Okay, that's a topic for discussion in another video. Now, what if your patient has a refractive error? That means the patient is wearing glasses. Do you carry out prism cover test with glasses or without glasses? The answer is both. You carry out the prism cover test with glasses and then you measure your angle of deviation at distance and also at near. Similarly, you also carry out it without glasses at distance and at near. The reason is because when you actually carry out the deviation at distance fixation with the patient wearing his full correction, the accommodation is totally relaxed. And whenever you carry out whenever you measure the angle of squint, when your accommodation is controlled, when the fusion is controlled, how are we taking care here? By doing the alternate cover test properly, right? So when your angle of deviation is measured in such a way that there is no influence of the accommodation or the fusion, we are basically measuring the static or the basic deviation. Okay, and however, if the correction of the refractive error is not adequate, okay, or we are measuring the angle of deviation without the correction, then the accommodation is obviously not controlled, and then the angle that we get, the angle of squint that we get, is called the dynamic angle of squint. Now, usually for the purpose of surgeries, it is the basic deviation or the static deviation which is measured. If you followed the entire video till this moment, give yourself a pat on your back. And now, let us understand what is primary and secondary deviation. So what is meant by primary deviation? Now basically you have two eyes. One eye is a fixing eye and the other eye has the deviation, also called the weak eye or the paratic eye, right? Now, if you are measuring the deviation of the paratic eye and the good eye or the non-paratic eye is fixating on the object, that means you are measuring the primary deviation. However, if you are measuring the deviation of the non-paratic eye by forcing your squinted eye or paratic eye to take up the fixation, then that is called a secondary deviation. So just know these sentences because now I'm going to explain it to you in detail. So let us see what is primary deviation. Suppose these are your eyes and the right eye seems to have some sort of squint, mostly anisotropia, right? Now, if you were supposed to measure the right eye deviation, how are you going to do it? You're going to place a prism in front of the right eye, and that would be a basal prism. So here you are trying to measure the deviation in the right eye, which has the squint, right? So that's a paretic eye. So this is called a primary deviation measurement. However, now if you place a cover on the left eye, what are you doing? You're forcing the right eye, which was the paretic eye, to take fixation. Now the right eye was already a weak eye that had squint, it was inwardly deviated. Now as you put a cover in front of the left eye, the right eye has to take up fixation to bring the object onto the fovea. That means the right eye lateral rectus has to do so much work to pull it outwards so that it becomes straight, right? So now the fixating eye is which eye? It is the right eye. But because of the Herring's law, what will happen? The medial rectus of the left eye will also get that strong innervation because of the Herring's law, right? The right eye lateral rectus had to do so much work to pull the right eye toward the center, and therefore the medial rectus will also get that strong innervation. And what will happen to the left eye behind the cover? The left eye will now assume this ESO deviation, right? So what has happened here? The eye which was originally having the problem, that is the right eye, which was a paretic or squinting eye, has now become straight and has become the fixing eye, and now you have deviation in the left eye. Now, if you were to measure the deviation in this left eye by putting a base out prism in front of the left eye, you are going to measure what is called a secondary deviation or a normal eye deviation. So I hope that is clear, right? Now, obviously, if I were to ask you what is the primary deviation more or secondary deviation more in case of concomitant squint or a non-concomitant squint where you have some sort of restriction or some sort of paralysis. Now here suppose your right eye had some sort of restriction. Restriction means say the medial rectus was very tight, okay, or paralysis, that means the lateral rectus was not working properly. So what will happen? There will be so much amount of innervation going to the lateral rectus, so in order to pull this esotropic eye outwards toward the center, the same innervation is going to the medial rectus as well, and therefore there will be esotropia in the left eye. Obviously, therefore, because of the increased innervation that is going in case of these non-concomitant strabismus, the secondary deviation is always going to be greater than the primary deviation. That means if you were to measure deviation in a normal eye, it is always going to be greater than the deviation that you measured in a paretic or in a paretic eye, right? And this is seen in case of non-concomitant strabismus, and this happens because of the Herring's law of equal innervation. Now here I have a question for you. What will happen and what will be the relation between the primary and secondary deviation in case of a concomitant strabismus? Okay, so answer that question in the comment section. So now we are done with the prism cover test. Now the question is, are there some precautions that you need to do, that you need to take while doing a prism cover test? Definitely. Prism cover test is based on dissociating the eyes, and therefore you are doing an alternate cover test. Do an alternate cover test properly, okay? Don't do it half-heartedly, half cover on the eye, because that will cause fusion and then you're not going to get the proper measurement. So prevent fusion by doing a continued use of alternate cover test. Never give the patient a chance to fuse or by using his both eyes at the same time. Give the patient adequate time to fixate accurately as you are doing the cover test. If you remove the cover too quickly, the patient is not going to fixate very properly and you're not going to get accurate results in prism cover test. So always do the alternate cover test slowly and give the patient time to fixate on your target. Always make sure that you are in control of the accommodation. Use a detailed target, use a 6x9 visual acuity line on the Snellens or an equivalent chart. Use accommodative targets on for the near measurements, okay? And make sure that when you're using those high powered prisms like 45 and 60, they will reduce the clarity of the vision, and it becomes very difficult for the patient always to actually fixate with those prisms also in front. So it's always better that you put those prisms, the high power prisms, in front of the better eye, which has some amount of good visual acuity. Now, sometimes you will have the angle of prism strength, sometimes you'll have the angle of squint, which will be too large. Sometimes you might not have those prisms also to measure. So suppose the angle is about 100 and the prisms available are only up to 60 prism diopters. So what are you going to do? In such cases, you could actually use a 60 and also a 40, okay, and you can divide the prisms. You can place 60 in front of one eye and 40 in front of the other eye. However, can you like simply add these prisms to get the angle of deviation? The answer is no. Okay, so suppose this was a patient who had alternating esotropia, and you were using 50 prism diopters in one eye and 20 prism diopters in the other eye, and you find that as you use these two prisms, there was no redressal movement. So now what is the angle of deviation? Is it 70? The answer is no. So then you have to use these tables which was given by Thompson and Guyton. Here you can see that in one eye you have used 50 and in the other eye you have used 20. So you go down and see the total is 78 prism diopters. Okay, so it is not plain addition. So 50 plus 20 is not 70, it is 78 prism diopters. So that should be very clear. Now, apart from that, kids, they can concentrate only for a very short period of time. So it's always better that in kids, you carry out your test quickly and you start your measurement with an approximately the correct prism. So say you carry out an Hirschberg's corneal reflex in these kids, and you find out that the reflex is actually present just at the margin of the pupil. So you know that the Hirschberg's corneal reflex, it is about 15 degrees. So if you want to convert it into prism diopters, how much it will be? It will be roughly 15 into 2, that comes to 30 prism diopters. So you start your test using somewhere around 30 prism diopter of a prism, and then go up accordingly, right? So that way you will save time and you don't have to deal with the short attention span of kids. Now, in the end, we would like to discuss how do you go about a combined deviation. That means there's also a vertical component and then there's a horizontal component. Obviously, in such cases, you cannot use your prism bars, so it's better to use the loose prisms. And it is always better to use these prisms in front of the same eye, because they can be concomitant in such cases if you were to actually split the prism. So it's always better that you mix the prism in front of same eye. Now the question is, which component are you going to neutralize first? Always neutralize the larger component and then go ahead and put a prism in front of it to neutralize the smaller component. Coming to what are the advantages, definitely it's very accurate to about 2 prism diopter. It provides complete dissociation and therefore it measures the maximum angle of deviation. So very good for measuring deviation before surgeries. It is performed in free space and you can measure the deviation at different distances, including the far distance. And if you remember this table in which we were actually comparing the different types of tests. In the previous video, we talked about the corneal reflection, and now the prism cover test. If you see, the problem is you cannot carry it out if the prism cover test if the visual acuity is too less. Okay, if the patient is not cooperative. Okay, and how or if when there's presence of torsion. So torsion and measuring of deviation in case of torsion, it's very difficult while doing a prism cover test. Does prism cover test require simultaneous perception? The answer is no, because we are anyways occluding one eye and you have to carry out the prism cover test in all the 9 positions of the gaze. So that's all for today. I hope you liked it. Thank you and have a nice day.